We have run out of time, actually, but I would like to allow for at least one burning question. Microphone number 3, please, Karen.
Great talks from everyone. I really liked your description and talk about de-escalation, and therefore one thing didn't really jive with that. We know that neoadjuvant is giving more and more to HER2 positives, anyone but stage 1. So all neoadjuvant therapy people don't start out the same. And when we get a PCR, I'm not sure where the data is for prescribing both pertuzumab and trastuzumab for all of those patients, knowing that many of them may have been a stage 2 and then got a PCR, whereas others might be higher stage. So in the mode of data or de-escalation, and also thinking about the last presentation where we know that although pertuzumab is safe, many people get diarrhea and other problems. Do you think we should be treating all of the PCRs the same?
Karen, I think that's a very good point, and as I said, my main justification for saying that if you started out with an HP regimen, it makes sense to continue is just because we don't have much data on shorter courses of pertuzumab having any significant long-term benefit other than the limited data from Neosphere. And I would just clarify that most of the toxicity of pertuzumab happens with chemotherapy and that most of the diarrhea goes away when you stop the chemotherapy, at least in most of the big data sets. But I think your point's well taken, and I think the strategy that Nadia had pointed out is also reasonable, and I think this is something that we need to think about as a group. Maybe we talk about it tomorrow as what is the best approach, because as I said, there's no right answer based on the data. We're going to have to be making some compromise in the absence of definitive data, and I think you could argue different approaches there. I don't know if Nadia, if you have any.
I mean, I showed the German AGO guidelines where we sort of take the affinity criteria also to prescribe HP after PCR, so only in hormone receptor negative and node positive. But I think that the greater danger is that people start to de-escalating after PCR without any data. And I think we should be very careful there and need to wait for trials that actually de-escalate also anti-HER2 therapy before we cut that short just because a patient has PCR.
We need the trials.
Yes.
I think we need to cut here, but I think that we didn't address duration of targeted therapy, which is very important. We didn't address as well what to do in very low volume persistent disease after neoadjuvant. I don't think that everybody should receive TDM1 with a very small persistence, and we didn't also address the IDFS issue in this trial, so that invasive disease-free survival, as what mentioned before by other, is not maybe the right endpoint in this kind of situation. Yeah, I think we need to close. Unless you have a very short comment.
There is someone at microphone number 5.
I'm oncologist from Pakistan. Just wanted to know your comments on phase 3 GCAM trial, which was presented at adjuvant capecitabine in triple negative, which was presented at San Antonio. So they showed that the benefit of adjuvant capecitabine was seen in a subgroup of patients who had non-basal-like phenotype. That is, their CK5, 6 EGFR was checked and that was negative, and these subgroup of patients benefited from capecitabine. So what is the implication of this trial? So should we consider that for all of our patients? Because in our part of the world, tolerance to capecitabine is not that good.
So there are so many negative clinical trials that it was impossible to review all of them. We should not forget that that trial have different aspects comparing to the CREATE-X, but the most important one is that in the CREATE-X, all patients did have residual disease. So this is a total different population. I agree that maybe in Caucasian patients, maybe CAPE does not produce the same compared with Eastern people. I don't know, but the point is that when you have the patient in front of you and you have the patient with residual disease, I think that you can choose between doing something or not. I think that for patients with high amount of disease, I think the CAPE is a good drug. You are not going to lose a lot of money and a lot of toxicity, so you can consider, you can discuss, but of course there are other trials. Also the US oncology trial with CAPE, including the adjuvant approach, was negative. So I think there are different concerns about the use of CAPE in the adjuvant setting, nevertheless.
Okay, thank you.
Okay, thank you very much for your interest, and I think we need to move ahead. And for those who are still interested in early breast cancer, please stay for the next session, where we discuss also young women and fertility issues, as well as HER2-positive breast cancer. Thank you.